Hello future doctors, welcome back to Conquer Pathology. I'm Dr. P and today we are cracking open one of the most clinically vital chapters in your Robbins, Infectious Diseases. We are covering the specific NMC competencies, Malaria PA10.1, Cysticercosis PA10.2, Leprosy PA10.3 and HIV AIDS PA9.6. Now before you say, Dr. P, didn't we just finish this in microbiology? Hear me out. This is the golden rule of integration. Microbiology is about the criminal, the organism, the bacteria, the virus. Pathology is about the crime scene, what damage they do to your tissues. Medicine is about the investigation and justice, diagnosis and treatment. I'm going to break down every single term. If I say granuloma, I'll tell you exactly what cells are in it. If I say sequestration, I'll tell you why it kills the patient. Grab your notebooks and a coffee and let's conquer this. Part 1. Pathogenesis and Pathology of Malaria. Let's analyze the enemy. We are looking beyond the vector and the species to understand the weapon itself. We are analyzing the invasion. Let's look at the enemy profile. Don't just memorize the names, understand that different species wield different weapons. P. falciparum, this is the heavy hitter. It targets all ages of RBCs and causes the most severe damage. P. vivax and P. ovale, these have a trick up their sleeve. Hypnozoites. These are dormant forms in the liver that cause relapses. And P. malariae, this plays the long game linked to chronic nephrotic syndrome. But remember the core concept. Pathogenesis is not just infection, it is damage. So how does it damage you? It uses a two-hit combo. Branch A is hemolysis. This is the explosion. It's the destruction of RBCs leading to anemia and fever. It's the noise you hear. Branch B is sequestration. This is the blockade. It's the silent killer that blocks blood flow and takes out the fortress. It is mainly seen in P. falciparum. Let's break down mechanism number 1, the explosion. First there is entry. The parasite enters the RBC. Consumption, it eats the hemoglobin and multiplies. Then detonation. Boom, the cell bursts. The parasite eats the hemoglobin and the pressure builds up for RBC. It is like bye-bye, tata, goodbye, gaya. It releases hemoglobin, digestion pigments and toxins. Loss of RBC count leads to hemolytic anemia. And crucially, when the cell bursts, the parasite's disguise is gone, the immune system wakes up. This wake-up call triggers the fever cascade. RBC rupture releases toxins like GPI anchors. Your macrophages detect these toxins, we call this the scream. They release cytokines TNF-alpha and interleukin-1. These hit the hypothalamus. The result? That classic shivering and fever spike. The fever isn't the parasite, it's your body's alarm system reacting to the debris. Now for the killer. Mechanism number 2, sequestration. This is a falciparum special. Normally, blood flows like a highway, but falciparum adds PFEMP1 proteins to the RBC surface. These proteins are like Velcro. It turns a highway into a parking lot. The RBCs stick to the endothelium causing cytoadherence, and they stick to other RBCs causing rosetting. The consequence of this traffic jam? Obstruction. Microvascular blockage due to clumping. Ischemia, disruption of blood flow, and hypoxia, no flow means no oxygen. This blockage is the root cause of organ failure, especially in cerebral malaria. The tissue simply suffocates. So where does the debris go? To the battlefield, the spleen. The spleen is the RBC graveyard, as we all know. In malaria, it works overtime to clear infected cells. The massive workload causes enlargement of the spleen known as splenomegaly. It fights the hardest, so it pays the highest price in structural damage. You need to know the difference between acute and chronic spleen. In acute malaria, it is soft, red and swollen due to congestion. In chronic malaria, it is massive, hard, brittle and black. This is due to fibrosis and pigment accumulation. Remember the texture, acute is soft and chronic is hard. Why is it black though? The parasite digests hemoglobin but cannot break down the heme. It turns it into hemozoin, a brown-black waste pigment. This leads to the ague cake spleen. Ague means fever and cake means a hard mass. If the spleen is black, it tells you the war has been going on for a long time. Just remember the term ague cake spleen. Now to the brain, cerebral malaria. Here we see Dirk's granuloma. This is not a true granuloma. There are no giant cells. or epithelioid histiocytes. It is a patch of necrosis and repair caused by the sequestration of parasitized RBCs in brain microvessels. Finally, the kidney, black water fever. Intravascular hemolysis spills hemoglobin into the plasma. The kidney cannot filter this sheer volume. Result, hemoglobinuria. You get dark black urine. It is a distress flare. It means the RBC destruction is out of control. There is renal failure. Let's recap. Mechanism: the two-hit combo hemolysis plus sequestration. Molecule is PFEMP1, the velcro of RBCs. Fever trigger are GPI anchors releasing TNF alpha. Spleen looks like ague cake, chronic, hard and black. Pigment is hemozoin. Brain gets Dirk's granuloma and kidney gets black water fever. Now let's solve a case that often confuses even the best students. We are talking about a parasite that turns the brain into a starry sky. This is Neurocysticercosis. Let's unravel the invasion. First, let's meet the agent, Taenia solium. It is a cystode, meaning a tapeworm. The common name is the pork tapeworm. It has two forms, the larva, which is Cysticercosis, and the egg. Now don't let the size fool you. This parasite creates two entirely different storylines depending on exactly which form enters your body. This brings us to the case of mistaken identity. The confusion here is, most students assume eating pork causes the brain infection. This is false. The core rule is the disease you get depends on whether you eat the larva or the egg. This is the most common exam trap. Pay close attention to the mode of ingestion. Let's look at scenario A, teniasis. Here you eat undercooked pork containing the larva. The larva matures into a worm in your gut, and you are the final host. This is an intestinal infection only. There are no brain lesions here. You just excrete eggs. Now scenario B, cysticercosis. This is the dangerous one. Here you accidentally ingest the egg, maybe from contaminated water, veggies, or dirty hands. The egg hatches in your gut and the larva migrates out. It invades your tissue, muscle, and brain. You have become the intermediate host. This is where we see neurocysticercosis. I know, looking at the life cycle makes you want to scream.
अरे कहना क्या चाहते हो?
But it's simple. Eat pork, gut worm. Eat egg, brain cyst. So here's the summary table, you memorize these. Teniasis, you eat the larva, you get gut worm. Cysticercosis, you eat the egg, you get brain cysts. Remember, the egg is the key to the brain. What does the lesion look like? We call it Cysticercosis cellulosae. Grossly, it is a small, fluid-filled cyst, about 1 centimeter in size. Inside you see a tiny white spot that is the invaginated scolex, the head of the worm waiting to pop out. Under the microscope, we see the structure clearly. Cyst wall, there are 3 layers of protection. The scolex, you can actually see the hooklets, and surroundings, there is usually an inflammatory reaction because your body is trying to fight it. When these cysts lodge in the brain, we call it neurocysticercosis. They can lodge anywhere. Parenchyma, inside the brain tissue, which is most common. They can lodge in the ventricles, blocking the flow of CSF, or they can lodge into subarachnoid space on the surface. This is the leading cause of adult onset seizures in many parts of the world. The pathology isn't static. It evolves in 3 phases. The viable cyst. This is the hiding phase. The degenerating cyst, the war phase, and calcified cyst, the aftermath. Let's look at them one by one. Phase 1, the viable cyst. The parasite is alive and hiding. It secretes molecules to suppress your immune system. There is no inflammation and the patient is often asymptomatic. The cyst is just sitting there unnoticed. Phase 2, the degenerating cyst. This is the war. The parasite is dying either naturally or because of drugs. The camouflage is lost. Your immune system launches a massive attack. There is intense inflammation and edema. This is when the seizures start. The inflammation irritates the brain. Patient feels exactly like this. Now phase 3, the calcified cyst. This is the aftermath. There is complete resolution. Dystrophic calcification occurs, the granuloma mineralizes. The cyst turns into a permanent piece of chalk. The active inflammation is over, but the lesion remains visible on imaging forever. How do we see this on a scan? The starry sky appearance. Calcium blocks X-rays, so it appears bright white on CT. When you have multiple calcified cysts, you look at the CT scan and it's literally tare zameen par, except these stars cause seizures. So if you see the stars, you are looking at the graveyard of the parasites. Let's wrap up with my high yield takeaways. The rule is you get cysticercosis by eating eggs, not pork. Humans are the intermediate host in cysticercosis. And the paradox, seizures often occur after the cyst starts dying due to inflammation. Now let's move on to the competency PA10.3. This is where microbiology meets pathology. We are talking about leprosy, also known as Hansen's disease. But we aren't just looking at a bacteria, we are looking at a spectrum, from the strong immunity of tuberculoid to the weak immunity of leprocy. Let's analyze the host response. First, you must understand the golden rule of leprosy. The bacteria doesn't choose the disease, you do. The agent here is Mycobacterium leprae. Unlike other infections, the bacteria is the same in every patient. It is your immunity that determines the disease type. This is the most beautiful example of immunology in pathology. The outcome is a direct reflection of your cellular competence. Think of it as the immunological seesaw. This is the Ridley-Joplin classification. On the left, you have strong immunity, the cell-mediated immunity. On the right, you have high bacterial load. The rule is you cannot have both. If your cell-mediated immunity is high, the bacteria count is low. This is tuberculoid leprosy. And if your CMI is low, the bacteria count is high. This is lepromatous leprosy. Everything in between is borderline. Let's start at pole 1. Tuberculoid leprosy, TT. I call this patient the fighter. The cell-mediated immunity is strong. The T helper cells, the Th1 type, are aggressive. They recognize the bacteria immediately and fall it off. The body fights back hard. What is the consequence of this fight? The granuloma. Because the immunity is strong, you see tight, well-formed epithelioid granulomas. The bacteria loves nerves. The granulomas form inside the nerves. The nerve is destroyed by your own immune system. This leads to early and severe nerve damage. Clinically, this nerve damage presents as a specific lesion, a hypopigmented patch with well-defined margins. Because the nerve is dead, there is sensory loss or anesthesia. If you touch this patch, the patient feels nothing. Bacterial load is paucibacillary. Very few bacteria are found. Now let's swing to pole 2. Lepromatous leprosy, LL. I call this the surrender. The CMI is weak or absent. The Th1 response has failed. The macrophages try to eat the bacteria, but they cannot kill them. The bacteria multiply freely. What does this surrender look like under the microscope? Foamy macrophages. The macrophages are stuffed with lipids and live bacteria. We call these Virchow cells or lepra cells. There are no granulomas. Why? Because the immune system isn't trying to wall it off anymore. If you look closer at these Virchow cells, you see this, the globi. The bacteria clump together inside the cell like bundles of cigars. We use Phyt Faraco stain, a modified acid-fast stain, to see them. This patient is highly infectious. Clinically, this is a total takeover. Without granulomas to stop them, bacteria spread everywhere, skin, nose, eyes. The face becomes thickened and nodular. We call this leonine facies, lion face. Diagnostic test is the Lepromin test. It is negative. This is energy. The immune system is asleep. This is the most high yield for your exams, the ultimate showdown. Let us compare. Immunity. TT is strong, LL is weak. Pathology. TT has granulomas, LL has foamy macrophages. Bacterial load. TT is paucibacillary, LL is multibacillary. You see the globi. Lepromin test. TT is positive, LL is negative. Finally, here's your exam strategy. Look for the keywords. If you see foamy macrophages, Virchow cells, globi, or lion face, the answer is lepromatous leprosy. If you see epithelioid granulomas, nerve abscess, or anesthetic patch, the answer is tuberculoid leprosy. Master these keywords and you master the diagnosis. Part 4. HIV and AIDS Decoded. Now we are tackling Competency PA9.6, Immunopathology and Opportunistic Infections, and we are talking about HIV and AIDS. But I don't want you to think of this as just a virus. I want you to think of it as a targeted assassination. The title of this lecture is The General is Down. Why do we call it a strategic defeat? We study HIV under immunopathology because the virus targets the specific commander of the immune army, the CD4 plus T helper cells. Look at the diagram. The commander CD4 issues the orders. The factory B cells, they need the order to make antibodies. And the assassins CD8 cells, they need the order to kill. Without the CD4 cell or the commander, the signal is blocked, the army collapses. Let's trace the invasion. Pathogenesis step 1, the entry mechanism. This is a classic lock and key scenario. The key is GP120. It is a specific surface protein that HIV virus possesses. This key, GP120, plugs directly into the CD4 molecule on the T cell surface. This is the first point of contact. But the key alone isn't enough. Pathogenesis step 2, unlocking the gate. After GP120 binds, it needs a helper to open the door. It needs a co-receptor. These are CCR5 or CXCR4. Some people lack the CCR5 receptor naturally, they are immune to HIV. Why? Because the virus has the key but no door handle. So these CCR5 or CXCR4 are door handles. Once inside, the virus takes over. Pathogenesis step 3, the hijack. Virus enters the nucleus and tells the cell. Virus uses an enzyme called reverse transcriptase. It converts its own viral RNA into DNA. This viral DNA inserts itself into your DNA. Now the T cell is no longer a soldier, it is a virus factory. This war happens in 3 distinct phases over time. Let's break down the pathology of each. Phase 1, the acute phase. The timing is weeks after infection, and the patient feels like they have the flu, fever, sore throat, rash. There is a high viral load in the blood. The virus is seeding into the lymph nodes. Phase 2, the chronic phase, also known as clinical latency. The patient feels fine, there are no symptoms. It is silent killing. The virus is replicating in the lymph nodes. The CD4 count is slowly, steadily dropping. The army is being assassinated one by one, and the immune system is like... Finally, phase 3, the crisis. This is AIDS. The immune system collapses. So what is the pathology of AIDS? It is defined by opportunistic infections. When CD4 count drops below 200, fungus, virus, bacteria all attack together. The body opens the door to every infection.
ओ भाई मारो मुझे मारो मारो मुझे मारो मारो नहीं ये मजाक हो रहा है एक सेकंड यार मजाक हो रहा है.
In lungs, you see Pneumocystis jirovecii pneumonia. Look for cotton candy exudate in the alveoli. In brain, you see microglial nodules. The brain tries to contain the virus. And in tumors, you see Kaposi sarcoma, HHV8, the purple skin blotches with vascular channels. Do watch this explainer video about narcos strategies of lab diagnosis of HIV/AIDS. Before we finish, let's do a rapid fire review of the previous topics to lock this chapter in. Cysticercosis, the pathogen is Taenia solium. You eat the egg, not the larva. Pathologically, you see cystic lesions with a scolex, and radiologically, you see starry sky appearance, the calcified cysts. Leprosy or Hansen's disease. Tuberculoid leprosy, you have good immunity, you see granulomas, severe nerve damage. Lepromatous, you have poor immunity, you see foamy Virchow cells plus globi, you see lion face. Well, now you are ready to answer any question on infectious diseases. Keep studying, keep drawing. This is Dr. P signing off. I've created a high-yield PDF cheat sheet of all these tables and flowcharts. The link is in the description. Good luck studying.